Thank you. For me, it's a privilege and an honor to be now here with you at the Texas Heart Institute and Baylor College of Medicine and Baylor St. Luke's. I could not even dream about this. I've known about the story of this place for years, even when I was in Brazil, and I could never imagine to have a chance to work with you taking care of patients. This is our team. There's a lot of people that have moved here with me that I'm very grateful. We have Steve Maximus, who is a vascular surgeon that has been working with me for a while. He was at UT. He also moved with me. And Dr. Huang, Ying Huang, who is the director of our endovascular research. And research fellows Bruno on the far right of your slide, and then Lucas and Dora on the left side. But let me tell you a little bit about me now that we're going to become family here at Texas Heart Institute. I'm from Porto Alegre, which is the capital of the southern state of Brazil, Rio Grande do Sul. Porto Alegre stands in Portuguese for Happy Harbor. And a few things about our state that you may know or not know. You may have gone to Fogo de Chão. The original Fogo de Chão is from Porto Alegre. I grew up every Sunday going to Fogo de Chão. And a couple of brothers, they decided to flee the city because it was so competitive. So they went to São Paulo, and then they went to the States, and you know the story. It became this big company. But that's where the gauchos are. And Fogo de Chão stands for fire in the ground, and that's how the gauchos used to do the barbecue. Just stick the meat and then put it in the ground. You may also know Gisele Bündchen, a top model that was married to Tom Brady. She's from Porto Alegre. And this is the best soccer team in the world, international. You can ask Dr. Perrin. He has a 3D print of the stadium in his office. But anyway, I actually grew up in this neighborhood. This is my parents' house. They still live there, very close to a yacht club. And of course, since age of 6, 7 years old, I started sailing, and I was very competitive. So I was in the Brazilian national team, tried to go to the Olympic Games in '92. I was in medical school, but didn't practice enough. So I was cast away, and I decided, I had a better chance in medicine. So I abandoned that and off I went to medical school. And then did actually a couple years of surgery in Porto Alegre, and then decided to come to the US and was very fortunate to land at the Mayo Clinic. And that was a symbiotic relationship. I think that Mayo gave me all the tools to excel and to make what I am today in terms of open surgery, endovascular. But most importantly, I met my wife there, Tanila Macedo, who is a radiologist, and she's also joining the faculty here. And this is our kids. The one that behaves very well is Gunnar. He's 10 years old. And then Gabe and Victoria here. But people ask me, why did you move out of Rochester? You had this amazing endovascular aortic program. And this is a satellite photo of Rochester in July, and this was a photo yesterday. But the truth is that I was very attracted to Houston because of the history and the legacy. And I mean, it's very impressive, particularly when we talk about aortic disease, how much of that history actually happened here, not very far from here. The first thoracic repair was done by Drs. DeBakey and Cooley in 1953. And then fast forward, they had several innovations with the introduction of Dacron graft. And then in 1965, Stanley Crawford came on staff, and really he entered the arena of open aortic surgery in terms of thoracoabdominal aneurysm in 1974 with his description of the inclusion technique, which is used to this date. And it's very impressive how fast things move forward for Dr. Crawford. In a matter of 10 years, he accumulated his first 500 cases, and just short of another 10 years, another 1,000 cases, and published in 1993, Drs. Svensson, Kozelli, and Safi published the results of their mentor, Stanley Crawford, with a remarkable mortality rate. And the story doesn't stop there. Joe Coselli then started his practice and rapidly accumulated the largest experience, becoming already in 2000 the surgeon with the largest experience in open thoracoabdominal aneurysms. And you can see, fast forward, as of last year, with nearly 4,000 cases. Now, I had the chance to participate in the writing committee of the American Heart Association for Aortic Disease, and it's amazing how actually endovascular was not even in the radar when we were first discussing what level of recommendation that would get. And you can see open repair is still considered the treatment of choice for the young patients with genetic disease, but endovascular with a fairly low level of recommendation is an option in patients that have anatomy that's suitable and in centers that have the expertise and access to this device. And there are many reasons why the level of recommendation was low, and we'll talk a little bit about that. Now, endovascular is more recent. It really started off in terms of the aortic work in Ukraine in the hands of Nikolai Volodus. Most of us didn't know that until years later because of the Iron Curtain. And then Juan Parodi, who really disseminated the technique in the Western world. Now, my story starts in 2007. I had the chance to train under Roy Greenberg, who is a pioneer on this technique. He passed away at a very young age, and he had very innovative and contributed with a lot of the designs that we still use today. But after I returned from the Cleveland Clinic, Peter Glovitsky, who was my mentor, was waiting with a patient that had a previous pancreatic necrosectomy for pancreatitis and a ventral mesh and had a symptomatic aneurysm. And I told Dr. Glovitsky, you know, we can't really do this endovascular because we don't have the devices available. But with creativity, we actually started modifying devices, and that's how I started off on this journey in 2007. And this is a CT scan of the very first patient that we treated with a 4-vessel fenestrated modified device. And in fact, over the course of the next few years, a lot of these techniques have really been described by our group at Mayo in the early phase of our experience. And fast forward to what we are now, it came the involvement with industry trials. We eventually got access to the entire pipeline of stents via a physician-sponsored IDE, which was now relocated here to Houston, to Baylor. And a lot of data has been accumulated on this technique. Now, currently, endovascular repair is considered, I would say, on almost any patient with suitable anatomy, and that's the key. It started off on elderly and high-risk patients, but as you see, based on the data, is an option for any patient with suitable anatomy. The one exception is really the patient with a genetic disease that has not been treated before, where we are still cautious about landing these stents in an aorta that is affected by a genetic process. There is one device that is commercially approved, that's the W.O. Gore TAMBI device, and we'll also talk a little bit about that. Now, in most centers, the way physicians handle this is with limited access to approved devices. There is only one device, as I said. It has important limitations of anatomy, and then with modified endografts. And there is a whole set of problems with using modified endografts, from quality control, reimbursement, potential legal issues. But we are very fortunate to have access to this entire pipeline, which includes almost any shape and form of thoracoabdominal device or arch device. This was a very long process to write the protocol, get it approved by the FDA, CMS, and then collect all the data prospectively and report annually to the FDA. Let me show you one case example. This is a patient that we treated at UT here in Houston, a 50-year-old with an enlarging arch and thoracoabdominal aneurysm. This patient has a very sad story. 10 years prior in Los Angeles, he presented with acute type A dissection and bilateral lower extremity ischemia. This was diagnosed late. which resulted in bilateral, very high above the knee amputations. He also had a colostomy bag. It was a very long hospital stay, and evidently this patient was not looking forward on having an open arch and an open thoracoabdominal repair. This is the CT angiography, and I want to point out a few things. This true lumen is very compressed. Some of the vessels come from the true lumen, some of the vessels come from the false lumen, and most importantly, because of his amputations, he now has barely any access and actually no access via the femoral arteries. So this is a summary, a little bit of his anatomy, and the biggest challenge here you can see is the true lumen is only 12 millimeters, so very compressed. So how did we do this case? Well, we planned a two-staged repair. The first repair would be done with an arch device using a conduit via the left flank. We anastomose a dacron graft to the common iliac artery. And notice here that on purpose, we place the device into the false lumen. And then we will connect the true and the false lumen using a transcatheter electrosurgical septotomy technique, which was actually borrowed from a structural heart cardiology experience. So this is the setup for the case. This was done in a hybrid room with only fusion, percutaneous axillary access, and then the conduit on the left side. Just a little bit of the case. You can see wire access in the false lumen, and a large sheath is advanced. We then gain access into the ascending aorta, and the fusion is calibrated, so you can see some of the anatomical landmarks of the supraaortic trunks and that ascending aortic graft. And this stent is just completely deployed under rapid ventricular pacing, and then using the percutaneous access via the axillary artery, we connect a bridging stent into the innominate artery, and then using a steerable sheath from the femoral approach, we catheterize the left carotid artery and extend the repair with a bridging stent into the left carotid artery. And actually on the subclavian, the true lumen was completely squished and the vertebral artery was coming from the true lumen. So I did document that we had collateral flow from the contralateral vertebral artery before we actually completed the repair into the subclavian artery on the left side. So now that we finished this upper part of the repair, we direct the attention now to the septotomy. You see a snare in the true lumen and a guide catheter in the false lumen. And this wire is then connected to the electrocautery and is used to traverse the septum. And we protect both ends of the wire with a hydrophilic catheter and then scrape the PTFE of that wire, which is this coating, and that allows transmission of energy to that septum. And I like to say this is like a lightsaber of Star Wars. I mean, without any force, you can actually completely disrupt that septum. And now we have the prepare for the second stage. Now on the second stage, I buried this conduit in the subcutaneous tissue of the groin and then put some clips. And then a month later, we made a small incision, found the clips, did a thrombectomy of that dacron graft. And through that, we are going to introduce a thoracoabdominal device that comes with 2 little catheters in the renal artery fenestrations and perform the case completely from a single femoral access site. So what you see here now is a catheter on the renal artery to locate the vessel. The device is deployed. If you note on the sides, those 2 lines are the preloaded system, and we advance 6 French sheaths through those preloaded catheters, and then we can access from the same side of the device each one of the renal arteries with catheters. And for the fenestrations, we want to gain access before we completely deploy the device. So you see on the drawing, the device is still not completely expanded. But once we complete the fenestrations, then we use a steerable sheath with a locking wire, and now we are going to do this again from the femoral approach, placement of these bridging stents. In the past, when we didn't have these steerable sheaths, we used to use the arm axis, but evidently with that arch device already there, we're really not looking forward to cross that aortic arch, and we were able to do this completely from the femoral approach. And this is the CT angiography after the procedure. Now, some other examples where we use this technique, this is a young patient with Lewis-Dietz syndrome and a large intercostal patch aneurysm. You can see, unfortunately, this intercostal patch was placed very close to the grafts that go to the mesenteric artery, so we had to request the company to design this stent specifically to complete the repair. This is another patient that I had. They had an enterocutaneous fistula and a thoracoabdominal aneurysm. He had a complete dissection of the mesenteric vessels, and we had general surgery, repaired the fistula, and then I did this bypass to the SMA and the hepatic artery, and it then became actually a quite easy case, very straightforward case without need of any prosthetic material that might get contaminated by that enterocutaneous fistula. Another example that was treated here in Houston is a patient on chronic mesenteric ischemia and total parenteral nutrition for over a year. I felt this was not suitable to an endovascular recanalization of the SMA, so I did a bypass to the SMA. I replaced the iliac artery, which was very small, with a Dacron graft, and now it became a very straightforward endovascular thoracoabdominal repair. And finally, this other patient, if you notice, the two right renal arteries are about 2 or 3 millimeters in diameter, so that's not suitable for any stent. And what I did is a modified ex vivo renal reconstruction where we clamp the renal vein, we do a venotomy, we cool down the kidney until it becomes white, and you can literally go to the cafeteria, have tea, and come back, and the kidney is still doing fine. And then we did a bypass here with saphenous vein, and it became a straightforward thoracoabdominal case. And this is another patient, actually, of Dr. Safi, who had a recurrence in the distal aorta, and evidently trying to do a redo open thoraco is a challenge with a lot of morbidity and mortality, and this was done with a completion repair. But I want to touch up on another aspect, which is imaging. I think that in addition of having this very sophisticated stents, we need excellent imaging, both in the preoperative phase and also in the OR. And I want to share with you a couple of examples where this is demonstrated. This is a patient that actually was previously treated by a prominent cardiologist here in Houston by trying to occlude this small little puncture hole in the Dacron graft, which was causing a pseudoaneurysm. And about 300 or 400 ml of contrast later, there was no way to find this little hole. And then I was consulted, and we were able to obtain a dynamic CTA, what you can see here, the little jet. And using this dynamic CTA, actually Dr. Macedo helped, we were able to map the exact location of this puncture hole and put a marker, a little orange circle on that. So if we go back to, let me make sure this is going to work. If we go to the case, you can see the fusion of the CT using the OR, and pay attention to that little circle in orange in the undersurface of the aortic arch. And I placed a catheter, and almost immediately the wire now is outside of the aorta and inside the pseudoaneurysm. And in fact, this little hole in the fabric was so small that a 6-French sheath didn't want to go through it. I had to downsize to a 5-French sheath, and then used one of the septal occluder devices that you guys use frequently to actually close that hole in the Dacron graft, avoiding a redo open aortic arch repair. So you can see the occluder there, and now I'm bringing that back exactly on that area and doing a little angiography, make sure that is in good position before I release completely the plug. And you'll see the angiography soon here. The plug is in adequate position, so we remove everything, and this is the rotational digital subtraction angiography. And I like to call this a glass CT angiography that Dr. Macedo did, and it's very nice. You can see the metallic part of the plug exactly in the location we want it. Another example, extreme anatomy, this patient has an iliac artery to venous fistula, almost like a malformation. And he's actually quite risky. And I'll tell you, this case is, you can do open, but it can be kind of a bloodbath. It's very difficult at times to control the venous flow from the pelvic in particular. So we did this endovascularly, and I use a creative technique to exclude the internal iliac artery aneurysm with a plug, we call a candy plug. But there was a large endoleak, and here is the importance of imaging to try to figure out these endoleaks. This is a dynamic CTA, and what we are seeing here is flow coming through the inferior mesenteric artery into the aneurysm sac, and then traveling all the way to the iliac system and exiting via the veins. So, and that was confirmed by ultrasound with these inverse waveforms. And what we did is we accessed directly the sac, and I was able to go all the way to the outflow. And I would say significantly improved the endoleak, although we were not able to completely eradicate the endoleak on this case. We have recently reviewed our experience with thoracoabdominal since I moved to Houston, and compared with the previous experience I had at Mayo. And one thing that is noticeable here is that over 80% of the referral actually comes from outside Houston, mostly from the south part of the US, but we even had one of my patients on the ground rounds here for follow-up, a physician from the University of Washington in Seattle who came for follow-up. So there are some patients from outside, but we're able to maintain in this large cohort now of 682 patients, a mortality of 1% across the board for thoracoabdominal aneurysms, including the cohort at Mayo and also the one done at the University of Texas here. If you note some of the events like dialysis, major stroke, permanent paraplegia, that is where the major benefit is of this technique. Now, despite this, it still receives a low level of recommendation. And why? Because, you know, the problem is single center experiences are not necessarily something that you can generalize to all the centers. And one of the most important initiatives we had now 5-6 years ago is to create a consortium of these 10 ongoing IDEs that we have in the United States. And this is really the only one here in Houston. And you can see the enrollment of these patients. We have approximately 40 patients enrolled per month, and that now allows us to do prospective randomized trials with this and hopefully have federal funding for some of those studies. We had a chance last year to publish on Circulation the data for elective repair of patients without genetic disease, and that was really the work of Dr. Huang. And you can see the mortality in the United States ARC for thoracos was 2.7%, including a rate of life-altering events, which is the combination of either death, dialysis, major stroke, or paralysis, that was 7.8%. Now, this is a very effective technique. We're trying to, of course, prolong life, but most importantly, prevent aortic death. And the rate of aortic-related mortality at 5 years was 3.8%, with a rate of aneurysm rupture of 2.7%. Taking into consideration that the median size of these patients are usually over 6 centimeters, you would expect a rate of rupture of 40 to 50% in 5 years. Now, the Achilles heel of this technique continues to be secondary interventions. The rate is high at 5 years, 40%, but the majority of these are minor procedures done percutaneously, usually to revise a stent or to treat a small endoleak. And most importantly, the results are reproducible. So I would say this is a democratic technique. You can see here the mortality varies between 1 to 4% in most centers. There is really one outlier in the US ARC, and that I think is a potential major advantage. Evidently, open surgery is also an option that should be considered on the young, fit patient because it's durable. And you can see that the rate of aortic reoperation at 10 to 15 years is very low. Now, we want to emphasize that aortic reoperation is not the same as secondary intervention. Secondary intervention, which is a benchmark we use for all these FDA trials, means any procedure that is a result of the index procedure or is a result from a complication of the aorta after the initial repair. And here are some examples of patients that have endoleaks, all with dynamic CTA. You can see after a frozen elephant trunk, an endoleak in the top of the stent, another one with branches to the mesenteric vessels and a very complex endoleak. And that's where dynamic CTA also becomes very important to differentiate. We also see in some patients stent stenosis from intimal hyperplasia or fracture. That's very rare that we have fracture, almost like single-digit cases. And inappropriate treatment with endovascular happens a lot. This is a patient that had a thoracoabdominal aneurysm and was treated partially with an abdominal stent and of course progressed the disease, and now it becomes a science project to do a fenestrated inside a fenestrated stent. Now, a little bit more about reinterventions. Yang Huang looked at experience at Mayo, and this is what happened when you have a successful endovascular program over the years. About 80% of the patients were treated primarily by endovascular technique, and the median age of the open surgical patients decreased from 70 to about 52 years old. And we did an analysis of the experience. This was at Mayo, and you can see the mortality rate favored endovascular, but there were substantial biases in patient selection with higher risk in the endovascular cohort. So Inc. did this propensity score method using overlap weighting methodology, and you can see that the advantages are really on almost every morbidity, mortality. There is not much of an advantage or difference in terms of spinal cord injury between the two groups. And using the propensity score, survival was similar in both groups. The instance of any secondary intervention was actually similar, up to 5 years in both groups. But of course, it favored the open surgical group in terms of aortic reinterventions, and it favored the endovascular group in terms of non-aortic reinterventions, which are things like hernia repair, bowel obstruction, etc. What is the status of these devices in the United States? W.O. Gore has been very innovative and fast-tracking almost the entire pipeline of aortic devices, and actually was able to have the first device approved in the US, and there are 2 trials by Cook Medical that are going to be here at Baylor. One is the ZFAN trial, which is almost completed, and then an upcoming trial next year with a thoracoabdominal device. The Gore device, I think that we can see remarkable results early on, no mortality. There was a rate of spinal cord injury that was 2% of permanent paraplegia. At 1 year, we have no publication yet, but there is the results are coming out soon. And I think that the one area that is an area that needs to be further assessed is going to be the rate of stent occlusion, renal artery stent occlusion, and how that's going to affect patient selection. Now, where do we go from here? I want to be brief in the interest of time. But 3 areas that I think that we are going to have to address. Of course, everything is going towards artificial intelligence, and we certainly need to embark on that and be part of this wave. That is going to be part of every step of the care of these patients, from diagnosis all the way to surveillance. And there is a lot of work now how we can systemically analyze imaging and facilitate actually the workflow and efficiency of our radiology colleagues and our teams that are making all these measurements in the aorta. So this is already ongoing, and it has been successful. This is, I like to give this example, is work of Diana Milevics and David Murdoch at UT, where they are feeding a neural network with photographs of patients that have known diagnosis of genetic diseases, and then analyzing millions of data points in the face of these patients to create phenotypes that can be identified just with photograph. And the idea would be that you have a patient in your clinic, you use this app, you take a photo, and that is analyzed by this algorithm, and then you can tell with some certainty whether they have Marfan's or Lewis-Dietz or vascular Ehlers-Danlos. And in fact, They already assessed this with nearly 2,000 cases, and they are actually, the last update she gave me, they're over 90% of accuracy on diagnosis just with a photo of the patient. Digital twins, how can we predict the behavior of these stents in the anatomy of the patient? That's also an area that has been already studied and is very promising, and we're going to be seeing more of that in the near future. The other area that is really the elephant in the room is centralization of care. We all know that if you need a Whipple procedure, an esophagectomy, an open thorax, or something very complex like an endovascular thoracic, you're probably better off in centers that do high volume by surgeons that do high volume. And you can see some of the data on Medicare. This is from over 14,000 open thoraces. The mortality in low volume centers was 26% and 15% for high volume centers, and only 1/3 of the patients actually were treated in a high volume center. And the mortality in centers like here, they have teams like Dr. Coselli, a process that's very organized, usually averages between 7 to 10% for an open extent 2 thoracic. Volume is important. Actually, even though this was for hemiarch and ascending aorta, you can see on a very large cohort that the inflection point is about 30 cases where surgeon meets the learning curve. And actually, we analyzed my learning curve, and coincidentally, it was about 30 cases per year. Now, how does these results of the USR compare with the rest of the United States? We look at the VQI data, and you can see the mortality is about 3 times higher. And you can see here a little bit of a summary of what I've been talking about, which is the mortality in the IDE, USR, VQI, and some of the open surgical cohorts. So it's no surprise that centralization is on every guideline, including the American Heart Guideline, and I think this is an area that needs improvement. Now, what do I see as a comprehensive aortic center? I think the first part is that the team has to be functional and work together. We need investment from the hospital into hybrid room and imaging, 24/7 access to this type of imaging. We need access to devices, which in the US for this type of practice means you have to have clinical trials or IDEs, and then a robust endovascular inventory, the research part, and the educational part. Now, finally, the last part is a non-radiation-based imaging. We're all affected by radiation. We need ideally a method that is going to be accurate, reproducible, agnostic of any imaging unit, low risk, and that will allow us to either completely take radiation away or diminish the amount of radiation. And unfortunately, we are in this era right now. We are not even close to the era of the iPhone or the smartphone. There are 2 leading techniques. The one of Philips is the fiberotic real shape technology. And the nice thing about that is you have a hub that you connect to the catheter, which simulates every shape of catheter you want. And also you can see deformity as you are advancing the wire or the catheter. You can see how it behaves in the patient. And these are examples by Carlos Timaran in Dallas using the FORCE technique. And then the other alternative is the Centerline Biomedical IOPS intraoperative position system, which is akin to a GPS, and that's already available. These are cases that I used to catheterize the mesenteric vessels without using any lateral view. And the limitation of that is you can only see part of the system and you don't see deformity. But several potential advantages. One is we were already working experimentally with augmented reality, where we would take the aorta out of the patient, floating in the air, and that allows you to do projections from the foot, for example, up that you can't do with a fluoroscopy. And you can see me playing around with a 3D model and catheterizing the branches, and the aorta is floating right in the middle of the room. You can also sensorize devices, and this is an experiment that we did ex vivo. We printed the anatomy of a patient. We got a CT scan of that 3D model. Then I sensorized a stent graft by putting multiple sensors, And then we're going to do this case in the hybrid room, except that we take the fluoro completely away, and we will do this using only IOPS. And here is just a little bit of a short footage of the case. You can see the setup. I catheterized the renal artery, so we know exactly where to go. The device is now introduced, and we adjust the parallax, see the deformation of the catheter when it's deployed. And now we are catheterizing completely blind this device, and then completed the repair with a CT scan without any fluoroscopy. And this is actually now a real case done at UT, where the device was sensorized. Now this was done as part of a pilot study. And look at the accuracy of my movement and the sensorized movement of the stent. It's very accurate in terms of the location. So I do see that this is going to be very promising in the future. Now, it's really not a tug of wars between open surgery and endovascular surgery. You need to have both techniques available if you want to be a premier center. Open surgery will have actually, I think, an increasing role in centers like here. There is patients with genetic disease. They will need patients that fail endovascular repair, patients with infected problems, and this is not going to go away. But certainly by working together, I think we can have results that are superior and actually offer our patients the best alternative. So in conclusion, for time and the world do not stand still, change is the law of life, and those who look only to the past or the present are certain to miss the future. Thank you very much for the opportunity to talk to you today.